we as chest physicians ignore quite often. And I think we struggle to deal with when patients say, I'm constantly tired or I'm not able to sleep, I'm anxious, etc. And Vidya has done, I've heard Vidya talk about this before, and I know she's the best person to do this evening. I actually know Vidya for I don't know how many years before I became a palliative care physician. We grew up in the same suburb in Bombay. Our fathers happened to be friends. And then she was my senior in MBBS as well as an MD. And then she led the path in palliative medicine, and I followed only 5 years ago. Currently, she's an assistant professor in the Department of Palliative Medicine at the Homi Baba Cancer Hospital and Research Center at Vishakhapatnam, which is a unit of the Tata Memorial Center. She is an honorary tutor also of the School of Medicine in Cardiff University, and she has set up independently on her own multiple programs in Vishakhapatnam for, I know how hard she works for the sake of her patients in Vishakhapatnam. So over to you, and Vidya, will love to hear you once again on this topic. Thank you.
Thank you very much, Rajam, for that very generous introduction. Just in the interest of time and to avoid technical glitches, I had recorded my presentation so that it goes in one flow, because this is a rather long topic with a lot of things. So I'm sorry you will have to go through a monologue, but I'm hoping that with the case, we do get the last half hour for discussion. So thank you so much. Happy New Year. And Rajlakshmi, if you wouldn't mind playing the recording, please.
Wish you all a very good evening. And dear pulmonologists, thank you so much for being here and spending this holiday evening with all of us. The session today is on non-respiratory symptoms in respiratory palliative care. So let's start by wishing each other new beginnings, because today this is a start of a new year in many parts of our country, and we celebrate it with different names, but the essence is always the same. So here's to new beginnings. The overview of my session today is going to be a rather long monologue, and I really apologize for that, but there is really no other way that I can do this. So the symptoms today that we will be covering are fatigue, insomnia, anxiety, depression, and pain. So the way I thought about this was that we would do the theoretical aspects comprising of terminology, the concepts, the assessment, evaluation, and focus more on this, and just touch upon the principles of management, and then think of an integrated care plan. And at the end of the session, we could get some time to share our experiences and discuss patient histories. So I'll start with fatigue. When we think of fatigue, it is one of those symptoms which is a very, very frequent system, but it can be very debilitating. But very often we underestimate the importance of fatigue and the impact it has on the patient. So if we need to define it, it impacts all the domains, the physical, the functional, the psychological domains, and it results in an inability to perform all your daily activities. It affects your mood, social relationships, work. There is so much to fatigue, but there is so little that we always do about it. So that's why fatigue is common, it's complex, it's multifactorial, it's unstable, dynamic, and very subjective. And most importantly, it remains underdiagnosed and undertreated. And it's not just the physical aspect of the fatigue that's important, it's also the mental fatigue. So you can have impaired mental concentration, you can have loss of memory, you have emotional liability, all of this with fatigue. I'm not even touching on cancer-related fatigue because that's a chapter of its own. So when we look at fatigue in all these domains, we also need to think about what actually contributes to fatigue. So when we have a whole lot of causes. Most of the time, we live in that misconception that it's only cachexia that causes fatigue. So suppose a patient has lost weight, is deconditioned, cannot get up, that's when he has fatigue. But we do see fatigue in patients who are well preserved physically. So for example, I apologize again because most of my examples will come from cancer as I work in a cancer institute. So when we see patients with early breast cancer, with lymphoma, with infections, we still see them with fatigue. So it's not mandatory that that cachexia is always predisposed, is always the predisposer to fatigue. But of course, along with cachexia, we have other contributors like inflammation, polypharmacy, symptoms, therapies, tumor byproducts, and anemia. Very often we underestimate anemia, which is a very important contributor to fatigue, infections, comorbidities. All of this can contribute to fatigue. And in respiratory disease, this is one of the interesting frameworks that we can see. So if we look into this, if we divide it into the A as the A part of it, then the B, the C, and the D. So what is the A part of it? The A part of it are all the controlling factors for fatigue. So what controls fatigue? So again, we look at this in the macro level and then move to the micro level and then the domains. So in the macro level, we have a patient with dyspnea, we have a patient who's physically deconditioned, we have a patient with anxiety, with depression, cognitive failure. But what exactly is happening in the micro level in his body? So here, there's a concept which we call as perceived fatigability and performance fatigability. So when we look at perceived fatigability, that is a trait. Performance fatigability is more of a state. So it is what it is at that time. And so that's a state. Whereas perceived fatigability is what is actually happening to them, which is more of a trait. So in the perceived fatigability, it is the psychosocial state of that patient, the mood of that person, the motivation that he or she has, the pain, all of these aspects that contribute. And then look at the body homeostasis. Patient is oxygen dependent. He has poor hydration, blood glucose levels, cardiovascular, all of these dynamics are the body homeostasis. So at rest or during physical activity, all this will contribute to perceived fatigability. Whereas performance fatigability is like I said, a state. So this is mostly during physical activity, where you have your muscle strength, your peripheral factors, your central factors, all of which are contributing. So it is these dynamics of A which actually impact B, or what we see as motor function, cognitive function, and psychological well-being. So consider all these factors, and that is the reason why the patient is fatigued. So now, is there any way that we can control this? And that is where we come to the modulating factors. So what kind of respiratory disease does this patient have? What are the tasks that he or she does? What is the severity of the disease? What is the environment that this patient lives in? What are the precipitating factors? If we could elucidate all of this, and then if we go to D and design new interventions. So can we do something about the performance? Can we do something about the physical activity? Can we do something during acute exercise? All of these factors could help in actually intervening in fatigue. So now, once we have come to this and we say that these are the factors contributing to fatigue, so these are the tasks that I'm going to set for my patient. You also have to be mindful that there is something called patient demands and patient capacity. So what do we mean by patient demands and patient capacity? We mean that there is something called a general demand and treatment demand. So our patient is also living his life. He also has the demands of his treatment. So when we say demands of his treatment, it means you must have given certain instructions to your patients. This is how you have to live. These are the tasks that you have to do. You have to do spirometry so often. You have to do your pulmonary rehab. You do this in good faith. But that becomes a task for the patient. So as the treatment demands and the general demands keep climbing, the patient's capacity after a period of time starts declining, because initially he'll have family, he will have everybody with him to help him. But soon, over a period of time, his resources start depleting. And the illness burden starts increasing. So we have to be mindful as physicians to understand that patient demands and patient capacity are two very important factors. So the general demands, the treatment demands, and the decreasing resources and the increasing illness burden. When this gap starts increasing, and this is what modulates fatigue. And once the patient becomes more and more fatigued, what happens is his adherence to treatment comes down. And why am I focusing so much on this? It's because one needs to monitor fatigue longitudinally. Taking one history of fatigue at one point in time will not be enough. We need to look at it longitudinally. So every visit that the patient comes to us, if we regularly assess fatigue, that is when we will pick it up really early and we can start our interventions early. So this is what I really wanted to emphasize in understanding fatigue. So how do we assess and evaluate fatigue? So we evaluate like how we evaluate our symptoms. We evaluate the severity, the onset duration, how it interferes with daily life, all of the associated psychological and social problems and underlying causes. I have put all of this in one line, but these are very, very important contributors because a lot of it depends on the background from where the patient is coming, what is he or she as a professional, what are the daily demands in his life, and what is it that he or she expects, and what are their goals of care. Then the functional capacity, which most of you will be familiar, task related fatigue, which is what I think is very, very relevant because the level of my fatigue would be very different from the level of somebody else. So each person to his own, and that's why the task related fatigue is a very nice way of taking history. We also have tools like the visual analog, the numerical rating scales, and of course the performance status of the patient. All of you must be, but there are some screening tools. I'm sorry, ESAS is not a performance status, it's a screening tool for symptoms. Then the KPS tool, then the ECOG, which most of you use. We as palliative care physicians use the palliative performance scale. And the key is that we need to evaluate in every visit. So once we start evaluating and we come to what we call as moderate to severe fatigue, what else do we need to evaluate in the assessment? We are going to look at onset duration. We are looking at all the associated and alleviating factors. We are looking at how it's changing over time and all of this. But along with this, what is very, very important is the disease and the treatment. Because the fatigue levels during active disease, during treatment, can also be significantly high. There will be a different kind of fatigue which will set in post-treatment. At end of life, we are dealing with a completely different kind of fatigue. When disease recurs, mentally the patient is completely drained, and so that kind of fatigue will be different. When disease progresses, then the burden and the disease progression with its symptomatology will cause fatigue. So what is the key is understanding at what trajectory of the disease and what treatment this patient is on, because many of our treatments sadly increase the fatigue. So what are the challenges that we face? So when we look at it as a symptom, it's a very difficult symptom because it's very ambiguous. There are so many mechanisms. It is so dynamic. It is multifaceted. And most importantly, each one uses their own scale. So we have multiple scales. So even if we want to review all of the interventions that were done, we have had different parameters and different scales in which we have actually seen them. So that is why it becomes very difficult as a symptom in itself. Patient fatigue. Now, can you imagine a patient with a huge illness and that burden sitting, and he actually having the gumption to tell his doctor that I'm feeling tired? That really doesn't count as an important enough symptom for the patient to address to the physician. So unless the onus is on us, unless we are going to ask them, we are never going to get this information out. And as far as physician factors are concerned, it's like that big elephant which is sitting in the room, because I know that my patient is tired, but I also know that there is really nothing that my textbooks have taught me about what to do for him. So what am I going to do? So it is such a subjective symptom. There is a lot of clinical inertia that we have. We are not adequately empowered to deal with fatigue. Most importantly, along with the gaps in knowledge, fatigue cannot be dealt with on an individual level. You need caregiver support, you need multidisciplinary team, you need talking time, you need to spend time with the patient, which does become difficult in our daily practice. But having said that, we really cannot ignore it. So now let us move from treating fatigue to at least managing fatigue. So at least after this session, if we start asking, evaluating, and trying to manage, I think that would be a big task forward. So if you look at it from the patient side, we need to empower them. We need to educate them. The minute you validate a symptom, automatically the patient starts feeling a lot better, because then the patient feels that, okay, this is something that happens to patients. This is something that is not unique to me. And if I try and pace my activity, if I start and resting in between, if I start and doing things the way that they've told me, I can actually start feeling less tired. And from the physician's perspective, it is accepting and acknowledging the symptom, which is also important. You need to identify triggers, and that's where a longitudinal assessment is excellent, is very, very important. So we always talk about anticipatory guidance before the actual problem sets in, a very proactive approach wherein you ask them every visit, and advanced care planning, especially in end-of-life scenarios. And most importantly, you need to work along with a team. It is a multidisciplinary team. You need continuous collaboration. You need good communication skills. You need to train, and you need to work very, very well with your teams to manage symptoms like this. So when you talk about this during treatment, if there is mild fatigue, we usually stick to general strategies of educational counseling, energy conservation techniques. And when we move to moderate to severe fatigue, along with the general strategies, we will use certain focused assessment, and we will try and correct the contributory factors to fatigue. We will also start using some non-pharmacological interventions. We will take the help of our physiotherapist. We will take the help of our counselor if needed, and then maybe combine it with some pharmacological interventions. But at end of life, the way we deal with fatigue is completely different. That is when we start eliminating all the non-essential activities. We start conserving the energy for what it is that the patient wants, not what I or somebody else wants. And we stop correcting reports, and we actually look at the person as a whole. We maximize the symptom management to the maximum possible. We try and address emotional distress, because that distress in the caregiver, in the patient, can be very, very significant. We optimize treatment for sleep, and we could consider corticosteroids depending on the prognostication. As far as management of fatigue goes, the highest evidence is for non-pharmacological. I have put in all the references towards the end, so all of you can read up about it. We also have an EBM on cancer-related fatigue, and so all of the references are given in the slides at the end. So the non-pharmacological management is actually primed for fatigue, and among pharmacological, we use very little medication. We do use Megestrol in cancer-related fatigue. We also use corticosteroids in cancer-related fatigue as burst doses. So with this, we now come to our next symptom, which is insomnia. So insomnia, if I need to define it, is difficulty in initiating or maintaining sleep despite adequate opportunity and circumstance to sleep. It is also associated with daytime tiredness. It's again associated with fatigue. You have disturbances in concentration, in mood, you start getting tense, you start getting headaches, you start having GI symptoms, you have a significant impairment of your QOL. And this sleep disturbance should be for at least 3 nights in a week, and it should persist for more than 3 months with night-to-night variability. Having said that, again, we have a lot of comorbidities and risk factors. So you are the experts in sleep disorders as pulmonologists. So that is not an area where I'm going to transgress. But along with sleep disorders, we have psychiatric disorders. We have prescription medications, which itself disturb sleep. We have we have substance abuse. We have caffeine, energy drinks, electrolyte impairments. We also have medical conditions. Now think of our patients who are breathless all through the day, who are with AIDS all the time. You have patients with edematous feet, you have patients with congestive heart failure, you have thyroid abnormalities, you have neurological conditions, and of course, add to that, you also have lifestyle shifts nowadays where people work with different rhythms, different time zones. And so all of these factors and some of these put together will definitely cause insomnia. And I just put up this slide to say that we do have so many sleep disorders, but the insomnia that we're going to talk about here is only going to be the insomnia disorder and chronic insomnia disorders. We are also mindful that obstructive sleep apnea has a lot in common with comorbid insomnia, and that is all for you to actually break down and treat. So in chronic respiratory disease, We have sleeplessness because there is a perturbed respiratory system and there is severe daytime hypoxia and or hypercapnia. There is dyspnea. Patient is having cough. He's having secretions. So, and there is a sense of sadness all the time. I mean, you don't like to be coughing even when you have a cold. And what if you have to live with it all your life, 24/7, 365 days? And then you have increased daytime sleepiness. And of course, in cancers, you have direct effect of the tumors, the result of therapy, and various other symptoms all put together. So when we assess sleep disorder, when we assess insomnia, the usual questions that we ask them is, are you having difficulty in initiating sleep? Are you having difficulty in maintaining your sleep? Are you having an early morning awakening? Are you having snoring and excess daytime symptoms? So this is regarding the basic sleep history that we take. And then we try and characterize the complaint, whether it's onset, its severity, since how long this has been happening. We also try and document the sleep-wake schedule and keep a log and tell the patient to keep a log, and also document cognitions. Most of this is done in tandem with the clinical psychologist, because after a point of time, the patient starts saying that, I know I'm not going to get sleep. That thought that I know I am unable to sleep because this is how it has been itself can cause insomnia. And then we evaluate what are the things that they are doing as daytime function. So we focus on all these three P's, which are the predisposing, precipitating, and the perpetuating factors, along with family history. There are, of course, tools like the Pittsburgh Sleep Quality Questionnaires, and we do have other and the questionnaires that you can deal with. But in principle, this is the history we take. When we look at principles of therapy for insomnia, there are again two groups. You can use the GABA agonists or the melatonin agonists, and you can use the MAO inhibitors or our antidepressants, and the DORA group, which is the dual orexin hypocretin receptor antagonists. So these are the main group of drugs that we use, and this is because it is based on this kind of neurobiology. But the most important therapy and the maximum evidence for therapy, even today in insomnia, is cognitive behavioral therapy for insomnia. This was one of the references for management in chronic disease, or an algorithm that we found. So again, this algorithm also focuses on cognitive behavioral therapy first. And if it is effective, it tells us to continue it. And if it is not effective, then we need to move on to the pulmonary function test, the arterial blood gases, and then you can start them either on doxepin or Svorexant. And only if this line is also not effective, you go further and give them benzodiazepines. As far as cognitive behavioral therapy goes, there are behavioral strategies, there are cognitive strategies. So as at our level as pulmonary care, as pulmonologists, as palliative care physicians, we could always start with this side, where we could talk to them about sleep hygiene, which is very important. We could talk to them about their routine. When we talk of sleep restriction, it's not actually restricting sleep. It is trying to make the bed a place where you only sleep. So any other activities you restrict there, and you consider the bed as your sleep time place. So you try and make the atmosphere around conducive to sleep. You try and give them stimulus control, relaxation techniques, good sleep hygiene, things that facilitate circadian rhythm. And then the cognitive strategies, the psychoeducation, this is mainly the clinical psychologist's domain. But the most important thing is that whenever we decide to work on insomnia and sleep, the first thing that we should do is find out why is it that they are finding it difficult to sleep. And when we know why is it that they're finding it difficult to sleep, is it a bad symptom that is troubling them? Is it nocturia that is troubling them? Is it the thought? Is it the thoughts of the disease that is troubling them? So unless that exploration into psychosocial distress is done, we will not be able to move forward. So once we have good control of the physical and the psychosocial domains, sleep will follow as a continuum. And yes, we do have drug therapy that's approved for chronic insomnia, but honestly, our prescriptions are mostly with the off-label drugs, because we try and use these medications for other uses. We try and use them for pain, we try and use them for cough, and automatically the sleep improves. So when we talk about pharmacotherapy, it's also about restricting drugs, because many times we give corticosteroids in the night, which actually prevents sleep. We give diet, and if the patient by mistake has been taking diuretics at night, that is going to upset his sleep pattern. So it is important for us to know that if there is a depressive disorder, and if the first line is ineffective, then we can start him on a sedating antidepressant. And melatonin in the elderly, or we can actually find combinations that will work for other symptoms and also induce sleep, like anticonvulsants for like pregabalin can decrease the insomnia and anxiety. Atypical antipsychotics, that's a very common drug that we use, can that when there is organicity, when there is vomiting, can be used, and that is when it also induces sleep. And so choosing wisely is very important. We need to use medications with caution, because we need to remember that when we are medicating for insomnia, we also have to be cautious about daytime sedation. We have to be cautious about dizziness, about nocturnal confusion, about cognitive impairment, and falls in the elderly. Another good drug here is mirtazapine now. And there is a recent article for evidence in treating cancer-related symptomatology. That's because mirtazapine, we can use it for pain, we can use it for sleep disorders, we use it for anxiety, we use it for anorexia because it improves appetite, we use it for nausea and vomiting, and there is also evidence for breathlessness. But this is, we do not have sound evidence yet, but this is a drug that many of us have found very helpful for symptom control, for multiple symptoms to be controlled. And so it would be an area where any of you pulmonologists can take it up and do a study on. And again, interrelated to sleep is psychological disorders. Why is it so important, even as pulmonologists, for us to identify psychological distress? Because if we actually look into this ourselves, if we retrospect, if we self-reflect, all of us know that if we are distressed in the mind, it impairs our capacity for pleasure, for meaning, for any connect. We lose all of that, and it erodes our quality of life. And what it does is it amplifies our symptoms. So it amplifies pain, it amplifies other symptoms that we have. It causes anguish, not just in us, but also in the family. And these are the kind of patients who will also refuse to take treatment because they're already so mentally disturbed that they say, I'm not going to add on to anything more. And this is also a risk factor for suicide and hastening of death. So when we look at the spectrum of psychological morbidity, we have it all. All our treatments, all our therapies, all our patients, and all the kinds of chronic respiratory diseases that we have will cause morbidity in all domains. So when we say all domains, we understand the physical domain. It causes functional limitations and all the multiple symptoms that are associated with it. Family dynamics are completely disturbed. Now, when we say family dynamics are completely disturbed, we also have to be mindful that this is not just family dynamics that are disturbed as per the disease, but each one of them comes from a family with a history. So in case there is already a psychiatric history, in case there is already difficulty coping in that family, in case the family dynamics are already very, very difficult set of dynamics that is going on, if there is violence, if there is abuse, if there is dysfunction, if there is some kind of unresolved grief, this can happen in families. And if we don't go back into that, we will be losing a significant part of history and our treatment might just not work. The patient coming to you would have abused substances, and today he must be living with that guilt. Why did I do this? Why did I not listen? And the family will be looking at him saying, I had told you so, and look what you're doing to us. So there are so many of these dynamics that are a constant. And there is a significant amount of what we call a spiritual distress, which again is not just related to religion, but it could be related to religion too, but it also is a significant part of why is all this happening to me? Why is it that I cannot live a regular life? Why is it that I have to be on oxygen all the time? Why is it that I have to go, that, I need to make this weekly visit or monthly visit or fortnightly visit to hospitals and spend so much time there? What have I done wrong? Is this some kind of punishment? So all of these are questions that are constantly going on in their minds. Treatment related, our medicines are not great because many of our medicines come with side effects. And in respiratory disease, they depend on life support machinery, they depend on other aids. And more importantly, there are multiple physician care providers. And so if you have multiple physician care providers and then you lack coordination, you're going to mess it all up. So that whenever I talk about integrative practice, I always emphasize that you need to integrate care, but you shouldn't fragment it. So if I tell my patient, you need to see the psychologist, you need to see the physiotherapist, you need to go here, I shouldn't be fragmenting it. I somehow have to blend it all into one holistic model of care. That onus is on me and my team. So it's the team which gives the results. But when we are integrating, we should also not fragment care because that can contribute to patient distress. And then the social factors. We always talk about the socioeconomic factors and the lower socioeconomic status and patients. But there is significant distress even in those who come from privileged social backgrounds. And why do I say that? Because you must be seeing it in your practice pretty regularly. You have elderly patients, you have patients who are dependent on oxygen, you have patients who are dependent on aids, who are living on top floors, who do not have access to probably lifts and do not have access to people. All their children are living abroad or their children are living in different cities. So here, nuclear families, elderly couples living alone, and probably single people living alone depending on or dependent on someone. So it's not always about money, but it's also about the support system that a person has. It's also the belief that they have been brought up with and the availability of supportive services. It takes at least a day for us if we have to arrange oxygen for a patient at home. And actually, thanks to COVID, it's easier now than it has ever been. But even then, so imagine if a patient did not have that kind of support, where will he be running around from pillar to post, trying to access, say an oxygen concentrator at home or devices at home or any kind of support at home? And where is the place in our homes to have all of this? So we need to look at each one of these factors because each of this is a significant contributor to psychological distress. So then when we talk about actual psychiatric disorders like anxiety and depression, we should be mindful that we do not use these words loosely because these come under psychiatric illnesses. Very often they are underdiagnosed, undertreated, or remain even untreated. And we always feel that, we are just not equipped to do that. And when we refer a patient, maybe we lose the patient because if we tell them to go to a psychiatrist, the patient will just stop coming to us. These are real world fears. Lack of recognition, lack of treatment, all of this contributes to negative outcomes. And in the principles of diagnosis, we must remember that these symptoms should cause significant distress and occupational dysfunction to qualify as a disorder. And these are usually diagnoses of exclusion. So when we look at psychiatric disorders, we should understand that it's a spectrum. We have what we call as major depressive disorders and general anxiety disorders. But in the spectrum, we have a huge spectrum of adjustment disorders, which is more of actually what we see. And then we should also not forget that there are anxiety or depressive disorders which are secondary to medical causes. So one should never forget that when we are discussing or when we are talking to our patients. So how do we understand this spectrum? When we look at this spectrum, we should see, we'll be able to see that we do have depression, we do have anxiety disorders, and we have adjustment disorders, and this is our normal response. So let's start from the normal response. Suppose something terrible happened to me today. I had a bad day today. So it kind of affects my mood, it affects my state, it affects of how I feel that day. But then this is day-to-day stress. I have learned to live with this. This need not always follow into a crisis. It could get resolved right here, or some issues could move into a crisis, but we still are able to respond normally to this, and we are able to take this in our stride and move along, even when we have a crisis. But adjustment disorders, now think about a situation where you have been diagnosed with a chronic disease. You have a diagnosis on your head. You're going to live with this all your life. The first impact is always shock. The first impact is shock, and then you grieve, and then you vent, and then you are miserable. You go through a lot of emotions depending on the kind of person that you are. It takes you time to adjust. So this is when you see your patients venting with you, talking to you, feeling sad, feeling worried, feeling afraid. They are going through a normal pattern of adjustment disorder. Anyone in their position would go through it. Now, this can happen for 3 months, it can happen for 6 months. But if you feel that this is continuing for way too long and these symptoms are overwhelming the person, is disturbing their daily routine, they are not able to carry on their daily activity, then all the alarm bells in your mind should start ringing. So in the diagnostic spectrum, if you talk about an adjustment disorder, it usually lasts for about 6 months, and you can have a depressed mood with it, you can be anxious with it, you could be fearful with it, your conduct could change, you could have a mix of various emotions. When you talk about anxiety, when you use the word anxiety, the predominant word that should come into our minds is worry and fear. So worry becomes a constant, and then you're unable to concentrate, you're unable to turn off your thoughts most of the time, you have trouble to fall asleep, you have so many crying spells, you have physical symptoms. All of this becomes the anxiety disorder spectrum. And then when you talk about feeling depressed, according to the ICD-10, your depressed mood or your depressed affect, it's how you feel, you're sad all the time. Anhedonia, where you lose interest or pleasures in anything. It could be a simple task that you do every day, but you just have no energy to do it. You have mental fatigue because of the depression. And then you just have lost interest in everything that you once used to do. You have your appetite changes. You either eat too much or you eat too little. Your sleep, you have sleep disturbances. You live with this constant feeling of guilt, that sense of punishment. Maybe I did something wrong. Why did I do this? And it impairs your concentration, ultimately culminating into thoughts about death and suicide. So this is how this diagnostic spectrum is. So, what are the essentials in the assessment and what are the challenges that we face? So, when we need to assess this, we first always start with exploring what the patient's understanding of their illness is. That it's of prime importance, because how the patient has actually understood this illness, what does he or she expect, what are the goals that they have set for themselves, what are their hopes, is very important when we are dealing with what are we going to do for you. And then we evaluate for all the organic factors that could contribute to the symptoms, like the hypoxia, the sepsis, the medications. We should not ignore these. Hypercalcemia, you can have vitamin deficiencies, electrolyte imbalance, all of these things can contribute to this. The challenges are when we have symptom clusters, which I will just touch on in the end, which will overlap. So you can have a person with major depressive disorder and a neurovegetative overlap in that, and you could have it with advanced medical illness. So what exactly is this patient having? It could be a challenge. You could have depression and anxiety disorders, but the symptomatology could be somatic. So again, it's a challenge. So there are certain boundaries which become really difficult and need a way more thorough assessment. Some helpful questions which we can use in our regular practice as pulmonologists, as palliative care physicians, as a physician in general are: how do we screen for depression? How do we screen for anxiety? So what are the questions that I can ask my patient? I can ask him or her, during the last month, have you felt down? Have you felt depressed? Have you felt sad? Have you felt hopeless? Have you been having less interest or little interest in the things that you do? And then gently, if they say yes to all of this, we ask them about self-harm. If I want to question them about anxiety, or as part of screening, my questions would mostly be as: have you been excessively worried? Have you been unable to concentrate? Have you been able to turn off your thoughts most of the time? And paramount to all these questions would be: is this affecting your daily activity? Are you able to do what you once did, or are you now unable to do what you once did? You also have the PHQ-4 questionnaire, which is again a simple tool which can be used. And with the anxiety subscale, which is the sum of 1 and 2, and the depression subscale, which is the sum of 3 and 4. If you feel that that these are significant scores, immediately that becomes your trigger to refer this patient to a psychiatrist. And along this, if your patients are responding to these tools, you do find adjustment disorders, and borderline anxiety, then it's time we start with the clinical psychologist and start the counseling sessions in itself. But these are red flag signs that is helpful to know. And when we look at principles in the management, again, paramount is non-pharmacological, psychotherapeutic interventions, the social support, the family interventions. And even when a patient is terminally ill, but he or she is depressed, it does not mean that we have to give up. There are still interventions that we can work on with the family and with the patient. So just because the patient is terminally ill, we don't need to ignore the symptom at all. And in the pharmacological, the commonly used medications are the tricyclic antidepressants and the various other groups of antidepressants. I have put up a chart which I can send it to you in the PPT. The most important key is how do you choose this antidepressant? Like I have said before, and I'm reiterating, we always choose it based on all the other symptomatology that the patient has. So I would like to use mirtazapine if suppose the patient is also having, that the patient is needs an antidepressant, the patient is unable to eat, unable to sleep. So he has all these and also has an element of neuropathic pain. I would like to use mirtazapine in these patients. We could also use tricyclics in patients when we are controlling neuropathic pain. If the patient has pruritus, along with these symptoms, they will respond to paroxetine or mirtazapine. If the patient has cough, they will respond to gabapentin. So if we kind of choose the antidepressant and try and tackle one more symptom with it, it actually helps the patient. When we look at anxiety, like I said, our assessment should include history, discussions with family and carers, physical exam, and also lab investigations. And the keywords: worry, fear, inability to concentrate. And again, non-pharmacological interventions are what is prime. And you have various kind of therapies. I cannot go into the details of each one of them. It's not my area of specialty. But we do start with things like a comfort bag, like telling the patient, keep a time for worry. If you're worried all the time, then just try. Keep maybe 1 hour in a day when you will worry. Then put all the things that you like the most into a little bag, call it the comfort bag, and say, look at it when you feel scared. And then have a bell next to you. And each one of you knows in pulmonary medicine that dyspnea and the breathing, thinking, functioning model that you've already done, how much anxiety is a contributor to dyspnea. So keep a little calling bell next to you. Make sure that your doors are not locked. There are a lot of non-pharmacological interventions which can bring down fear, which can bring down worry, and actually bring down anxiety, of course, along with good symptom control. Preserve the care tenor, treat the patients not just as a disease, but respect their dignity, respect what they want, treat them with compassion. This is a given. We keep saying it and we keep training everyone with it. We have to tell this to ourselves also every day and be mindful, because many a times when we see too many patients a day, sometimes we can also have a slip. And the various pharmacological interventions are the benzodiazepines and your serotonin specific reuptake inhibitors. Now, coming to the last part of our session today is we dealing with chronic pain. Now, this is really a task in itself. So again, I thought I would focus on how we approach pain as palliative care physicians. So for us, pain is an unpleasant sensory and an emotional experience. As much as it is a physical one, it is a somatopsychic phenomenon. And we always look at the patient's mood, the morale, and what meaning this patient has for this pain. Why do I say that? Because I'm not talking about acute pain. I'm talking about chronic pain, something that the person is living with all the time. And so Robert Tykross's definition is what holds. Pain is what the patient says hurts. So when we look at the types of pains, we have acute, chronic, nociceptive, neuropathic pains. So nociceptive could be somatic, from our bones, from our muscles. It could be visceral pain. It could be neuropathic pain, either because of nerve compression or because of nerve damage. It could be all along the spectrum: procedural pain, treatment-related pain. And pain at end of life would be different. Pain of metastatic disease would be different. Survivors have a different kind of pain. So you have a whole spectrum of pain. So it's always important to know where is the trajectory of your patient when you're dealing with pain. And so the principles of our assessment is mostly to characterize the complaint and also to focus on what is the pathophysiology of this pain and what is the impact on this patient's life, because that is what will guide our choice of treatment. And the concept of total pain, assessing and reassessing, is extraordinarily important. So when I say total pain, I have to have Dame Cicely Saunders there, because she was the one who brought up this concept of what we call as total pain, just like how we spoke about psychological morbidity in all domains. Total pain affects all domains, and each one of us is familiar with this now, because it is not just the chronic respiratory disease that we are dealing with, but it is the illness experience for that particular person. So we have to start by taking a step behind, keeping the disease in focus, but keeping the person in mind. And that becomes the illness experience. So always think of what is the physical damage that is happening here, what is happening to the dynamics, who is that caregiver who's standing behind the patient, what is he or she going through, is this patient angry, upset, and is he going through spiritual distress or emotional distress? So these are things that should be continuously on your mind. And requisites of a good assessment include history, include labs, include the effect of pain, include the effect of what the previous analgesics have been for this patient and what has been their experience, and also what is his goal and expectation. It's not to bring the score from a 10 to a 0, but it is what is the patient's goals and what is the best that I can do. And the most important thing is you can only do this if you have a good, trusting relationship with your patient, and that is for us to create. So some helpful questions in history. We always go as, of course, the site, the frequency of the pain. So we ask them whether it's continuous, whether it's intermittent, how many episodes in between, what is the impact on your activity, how does it affect your sleep, how does it, what are the medications that you're taking and in what frequency. Easier way of remembering it is an OPQRST, where we talk of onset, what are the provocative and palliative factors of your pain, what is the quality of your pain. And I'm sure in every parts of our country, we will have very, very interesting descriptors for pain, and each one will express it in a different language, as chupta hai, chun chun hota hai. So you have so many different ways of pain expression from the patients. It's nice to listen to it, and that is what will actually tell you what's a kind of pain. Does it radiate anywhere, or is it referred pain? What is the site, the severity, and what are the temporal factors? We also have different scales to judge severity. We use the visual analog or the numerical rating scale. In children, we can use the Wong-Baker faces. And we also have a map in which we actually put in as 1, 2, 3 if there are more than one pain. And 1 is the area of most severity, 2 follows, and then 3. So we mark it there. And why am I saying all this? Because again, it is a longitudinal assessment. You don't take a pain history on one day and forget about it. And then when we move to character and radiation, this is what will tell us what is the kind of pain. The pathophysiology will actually come through the character and radiation of the pain. You can have questionnaires for neuropathic pain. This is one of the common questionnaires that we use, the DN4 questionnaire. And then the timing of the pain, we also tell the patient to maintain their own time diary. We tell them to write down what troubles them, at what points they have breakthrough pain, at what points they have intermittent pain, at what point they have episodic pain. So we explain all this to the patient and we tell them to actually write it down. So when we talk about pain assessment, the word I would like to use is, it is synchronous and sequential. Why synchronous? Because as the patient is describing the pain to you, the doctor reflects on the cause, on the mechanism, the contribution of the non-physical factors, and is actually coming to a conclusion on how I'm going to manage this pain. And it has to be sequential, because only then you will know how your medications or your treatment is working. Management is, of course, both non-pharmacological. Pharmacological is based on the type and the intensity of the pain. The WHO analgesic ladder is what we use day in and day out. So we start with non-opioids and adjuvants, then move on to the weak opioids and then strong opioids. But what needs to be remembered is 2 things. One, the psychosocial spiritual support will move all along the ladder. The second thing is, you do not have to go to the ladder one step after the other. Severe pain merits step 3 right away. So this is how we usually start. But like I said, you don't need to climb it step by step. The principles of the WHO ladder is that we use it from by the clock, by the mouth, by the ladder, and an individualized approach. Because we need to remember that giving an injection is not going to help this patient because he's going to have chronic, constant pain. So this is the list of the non-opioids and opioids that we have. Tramadol comes in the step 2. Tapentadol is now a step 3 opioid. So tapentadol, morphine, and fentanyl and methadone are what we have in our country as step 3. In the non-opioids, we have paracetamol, which is the key for most of our pain management. We do have NSAIDs, which we do not use, which we use in very specific conditions. But otherwise, the usual combinations that we use in cancer pain is paracetamol and opioids. And of course, adjuvants, because for neuropathic pain, we need our adjuvants like anticonvulsants, antidepressants. These are what we use. And then we also have adjuvants like antiemetics, which need to be given along with the opioids, the antispasmodics, which we need to be given for some kinds of visceral pain, antibiotics, anxiolytics, antacids, bisphosphonates, all of this. The guiding principles are that chronic pain is constant. It needs regular medication. We need to choose the routes of administration. So a patient on end-of-life care, we might choose to give them a subcutaneous or an intravenous medication. So we need to choose that. And many times we see prescriptions where a sustained release morphine has been given, but there is no immediate release with the patient, which is actually not a good prescription at all, because when we give sustained release medication, we also need to give them an immediate release one, because they need that medication to take intermittently whenever they have breakthrough pain. Switching opioids, managing the side effects, and assessing total pain is our responsibility when we prescribe opioids. So now, as I come to the end of this session, I just thought I'd highlight, you must have realized along the way when I started with fatigue, insomnia, moved to psychological symptoms, and then to pain, you must have realized how interrelated each one of this is. And that is why in our assessment, in every assessment, we use what we call as the Edmonton Symptom Assessment Scale, which is one of the screening tools. And here you can see all the symptoms that I just spoke about, the pain, fatigue, whether they're depressed, anxiety, sleep being some of them. So when we do this every day and we see the symptoms going beyond 4, then we know that our mind has to start thinking. So even that visual impression of the scale is enough for us to know whether this patient is having difficult symptoms or symptoms that can be easily managed. And when we look at this on a regular basis, we will find that our symptoms come in clusters. Very often, we see symptom clusters. So in COPD patients, there are 4 distinct anxiety symptom clusters. So there will be somatic distress, there will be fear, there will be nervousness. There's something called a respiration-related cluster, like dyspnea, cough, and anxiety. So you can have a pain, depression, and fatigue cluster that you see in lung cancers. So these clusters are important and interesting, because if we bring down the pain, we can automatically bring down the other symptoms too. So that is the importance of recognizing symptom clusters. There is also a recent article in Chronic Obstructive Pulmonary Disease about symptom clusters and how there were 2 themes in this study. One was a psychological symptom cluster and one was the respiratory symptom cluster. But because of the heterogeneity among the patients and the instruments and the statistics, we really couldn't get adequate data. So I would like this to tickle your brains a little, and maybe an area of collaborative research could be COPD associated symptom clusters that each of you could take up as a study or do a multicentric study. And finally, we come back to integrating care. Why are we all here today? Why are we spending this evening sitting together as pulmonologists, palliative care physicians? Why are we doing this? Because finally, we want the best for our patient. And how are we going to do this? We're going to integrate care. So I have just put up some evidence that we have found from respiratory, in the context of chronic respiratory disease. So this is one of the models where we need to be mindful that as the complexity of symptoms keep increasing, we need to change our levels of care. So if we start with a level 1 for our regular patients, where you can provide them with generalist palliative care and specialist respiratory care, we might have to move on a bit as the patient's symptomatology gets worse. So as the symptoms get more complex, we go into level 2 and then into level 3, where we will start involving specialist respiratory care along with generalist and specialist palliative care. So this is called movement between levels. If the patient is doing better, we can always come down to level 1. So this was one model that was described. And the other models that have been described is indications for palliative care. So as a pulmonologist, when am I going to refer my patients? So I could have my cutoff. I could use symptoms. I could say if I have complex troublesome symptoms, maybe I'll take the help of palliative care physician. If I have unmet family caregiver needs, if this patient is having too many hospitalizations, if they are going into acute inpatient care for respiratory failure, maybe their lung bells have started ringing, if they are on oxygen therapy, if there is a deterioration, if they are not able to attend pulmonary rehab, these could be my triggers. Or I could have a working model in my own unit. So here is an area where you can creatively design your own models for integration. And this is in the same article, they have described the lived experience of patients. So as we are talking about what we can do as pulmonologists and respiratory care and palliative care physicians, it's also important to understand what the patient wants. So this article has described the lived experiences. Patients want to understand their disease. They want sustained symptom control. And the psychosocial effects are also significant. So these are domains that we need to address. When we need to address these domains, we need to have a system in place. And what is that system? We cannot escape having a multidisciplinary team to do all of this, because we cannot do this individually. So there is also a nice article on interstitial lung disease and what are the needs of patients in interstitial lung disease, which has been described beautifully in this diagram. And it also talks about patient education. It focuses on patient education, which is very, very important. And there is also a flow chart over here, which talks about what is the impact of diagnosis and what is the immediacy of palliative care conversations and how we can follow this and how we can have a disease behavior-based algorithm for interstitial lung disease. And there is also a beautiful ABCDE here, which says we need to assess patient needs. We need to back them up with good education and self-management and pulmonary rehab. We also need to give them comfort care and address their comorbidities. We need to give them disease-modifying treatment and also planning end-of-life care. So I think this ABCDE forms the crux of what we have been talking about today and why we need to integrate palliative medicine into pulmonology. So when we form our care plan, we don't forget the history. We don't forget the assessment. We have a good therapeutic approach. We find out from our patients what is it that they want. We talk about prognostication. So if we put all these pieces together, we have the pathophysiology, we have the psychosocial, we have the pharmacological, we have the non-pharmacological, we have the prognostication, very important pharmacoeconomics, and of course the practice of medical ethics, because finally I'm here not to do harm to my patient. Team building is very important. When we talk of integrative practice, we have to have the generosity of spirit where we need to network and collaborate. You have your strengths, we have ours. How are we going to put all this together in improving patient care? So that was what this was about. And thank you so very much for this extremely patient hearing. And we will be ready to take on any more questions or share your experiences. Thank you very much.
Thank you so much, Vidya. Every time I hear Vidya, and also when I first trained myself in palliative care, I wondered after finishing the after finishing the session, why they never teach any of this to any of us in our curriculum. Not just as an MBBS student, but even as a respiratory physician, we are so focused on dealing with cough, breathlessness, hemoptysis, pleural effusion, pneumothorax, latest technologies available. We never think of what our patients go through. We never think of how they are struggling, their suffering, and how we can provide them holistic care. And very often I think we also get stuck and not ask patients about fatigue, pain, insomnia, because we also don't have the answers, and it's a dangerous territory to enter, because then it will start the patient saga and we are not equipped with that information. So thank you very much, Vidya. Every time I have learned out 2-3 more important things. So I think the more I listen to you, the more I will learn. But please, all of you, because it was recording, we couldn't interrupt it, but you can now interact with Vidya so that you can share your patient experiences, some anecdotes, some things that you have experienced, and how you think this talk will make a difference in your practice. Because I really think we don't want to venture into it because we are scared to even ask them about pain, fatigue, appetite, insomnia, etc. So please go ahead. Vidya is here, and then we can go to the case presentation. So there's one question, Vidya, from Varuna Jethani. How much fentanyl patch can be used for malignancy patient? Patient is better with use of patch. Any limit? So it's a question.
Thank you so much. And the thing is that's how much fentanyl patch can you use? Any limit? Usually that question will be answered when we go back to see how much morphine is this patient taking. Because please remember two things. I see it very often, and is that, automatically somehow it's probably more easily available. So patients come to us with patch, but a patch is never started without dose titration. And when I mean dose titration, it means that and the principle in morphine is two things. One thing which I did not put up in my slides, and maybe I should have, is that we have opioid resistant pains or opioid non-responsive pains. So that's why I focus so much on the assessment. Because if you have bone pain, if you have headache because of raised ICT in a malignancy, and the patient just comes to you with headache, if you have a strong neuropathic component to the pain, if she's had a rib fracture, this pain will not respond to morphine. It will just not respond. And what you will see, so it always helps. The way we start morphine is, I give them an oral morphine trial, because I know that injectable is very hard to get, not possible for all patients. We give them 5 milligram, talk to them, make them sit in front of you in your OPD. You can see your other patients at that time. And in the next 40 minutes, the patient will tell you what the response to morphine was. And once you've done that, you start. And the key to morphine is explaining it, writing the timings, and telling them the 4th hourly dosing. In breathlessness, we start with 2.5, and I start even lower. I go 2.5, maybe 6th hourly or 8th hourly. Whereas with pain, the usual dose is 5 milligram Q 4th hourly. We start with this along with the adjuvants, and then we give it to them and then tell them to get back to us. Now, suppose your patient is comfortable with 5 milligram Q 4th hourly morphine, which means 30 milligram a day. Then the equivalent dose of fentanyl will be a 12.5 microgram patch. The easiest way is to divide it by 3. Of course, the calculation is there because of the potency. It's hard for me to go into it in this short a time. So then you can, if your patient is comfortable with 5 milligram Q4 hourly morphine, then you shift him to a fentanyl patch of 12.5. Suppose you're in a place where it's really hard, you need to start them on a patch, you don't have access to oral morphine. Is your patient on at least tapentadol or tramadol, at least a dose of 300 to 400 milligram of tapentadol or tramadol a day? And tapentadol, tramadol again have varying, the tramadol, which is 200, you should have a 400 of tapentadol. That's the equivalent. And for those patients, again, a 12.5, patch of fentanyl might work. But the key is to know whether your patient is responding to morphine and find the equivalent patch. Please don't start the patch right away. The same rule applies for SR. So sorry for that long answer, but I think it was really hard for me to fit that into the topic, but I know how important it is.
So Vidya,
I can definitely share key points. I can send you the presentation on that, so that shouldn't be a problem.
Sorry, Vidya. I know we had a chat about a loss of appetite, and we said the talk would be really long. So, any quick key points, or would you like to share some article even on after you finish your talk is fine, but anything that you could share with them in a nutshell about loss of appetite in patients with respiratory.
All right. So again, loss of appetite the most common reason I find is, the first question I ask them is, are you hungry and you're not eating, or you're unable to eat? Or is it that you just don't feel like eating? So again, the reason for that is important, because you'll be surprised, but a lot of our patients will have oral candidiasis and esophageal candidiasis. That's the first thing which we need to look. So a torch in your pocket is mandatory. I mean, you will be surprised. And I know that many of you all give your, your oral steroids, and and many a times they don't rinse their mouth or wash their mouth. And oral candidiasis, and especially esophageal candidiasis, is a very, very important cause of loss of appetite. You'll be surprised once you start doing it. Then after that, you ask them about the type of food, because very often patients with breathlessness, patients with respiratory symptoms cannot eat solid food. So we usually talk to them about the consistency of the food, about the quantity of the food, and breaking it up into multiple small meals, which are semi-solid. And so that is what really, really helps them to eat. And the minute we tell them this in front of the family, and we tell them, even tea and a biscuit is a meal, then they feel, okay, this is something that's doable. Because, and we also tell them, see, if you have a cold and when you are sick, how much are you able to eat? Then they understand that, being sick all the time is itself a cause for anorexia. You're not moving around, so you're not spending that energy. All those are contributors for anorexia. So the anorexia, the type of food, the consistency of food, the frequency, and a lot of it is caregiver counseling. I could really share something, but I think someone has gone into it.
Maybe you could share an article, Vidya. If there is something, then we could share it with all of them.
Sure, I'll do that.
Couple more questions. Somebody from Pallium India needs to keep a track of the time for the case presentation.
Yeah, because I don't want to miss the case, please. Please feel free to.
So there are a couple of questions, and then maybe if there aren't any, we could go to the case. One is, patients with multi-drug resistant tuberculosis are nowadays given linezolid, which causes intractable neuropathic pain. The Dr. Shreyas wants to know, what is the maximum dose of gabapentin you can use for such patients of neuropathic pain due to drug-induced or even otherwise, say diabetes or whatever. Yeah.
Again, my experience comes from cancer. So we usually, for cough, I start with 100 milligram TID. If it's pain, again, start low, go slow. Don't rush to the higher doses. So I start with 300 milligram HS if it's for neuropathic pain, and then slowly up it to 300 milligram TID. Usually 300 milligram TID as an adjuvant along with others works well, but you can go as high as 1200 milligrams a day. You can go as high as that. That's what evidence says.
The next question is treatment of chronic anemia, which we do see in patients who have in chronic infections like bronchiectasis, etc., or also due to malignancy. The question here from him, Parik, is, should we every time go for blood transfusion, anything specific apart from iron or multivitamin?
Well, that is, it's a tough call. Where I see that problem is in hematological malignancies. So when you know that everything is going down, so again, fatigue is very valuable. If your patient, that is why I think a longitudinal assessment works. If suppose you have seen this patient with a good enough hemoglobin, was doing well, but now your only other thing is that hemoglobin has gone down and your patient is not able to do the tasks that they want to do. That's important. Does my patient want to do the tasks that they want to do? Then I think you can transfuse. But suppose the patient is on a declining trajectory, patient is going towards the end of life, is barely able to get up. At that time, you're only going to treat that report. You're not going to treat the person. So again, the trajectory, the patient's expectations, that I felt much better after our, our last, after the last transfusion that I had, and maybe that's why now after this gap I can have one, then it's fair enough. So I think it's a very individualized approach.
So I think that is very important for everything, in the sense when you have a patient who we end up treating numbers and not the human being, we need to treat the symptoms that affect the quality of life directly, and that could be non-pharmacological or pharmacological. And very often we end up doing unnecessary investigations with the patients and doctors just for the sake of doing it. Every third day creatinine, every third day hemoglobin, Does it really make sense is what we really need to see, and how it's affecting and transforming into improving the quality of life of patients. Or is it just making the caregivers feel I have done everything and I have done the blood tests and I'm going to keep reporting these things. So please remember, we treat humans. We should be treating the persons and not the patient. No, don't go beyond numbers. If any symptom is affecting the patient's quality of life, yes, it does merit your attention. There are some more questions coming in.
Excuse me.
Yeah.
Just a minute,
Yes.
Dr. Rajam, if you don't mind.
Yes.
See, I have been a chronic pain, non-cancer pain physician for more than 10 years. So
Yes.
just to answer the neuropathic element alone,
Sure.
see, as Dr. Vidya has mentioned, 900 to 1,200, you can go up to 1,800, that's the allowed. But going with the patient response, you need not be worried or scared when you go to 900. There are few options. You can give 300 morning, 300, and give a 300 plus something in the night dose. So doing a proper titration on patient basis, because neuropathic pain will respond and you have to be a bit patient with that. Sometimes they may not get what by books and guidelines, what they say is you go gradually for a period of up to 1 to 2 months and then wait and see. You can't say that it's not working within 2 months, that is 6 to 8 weeks. Because it doesn't work like other painkillers. Neuropathic pain has to build up in the blood level. So if I have titrated or increased it. So once you go up to 900 and then after that you can increase the night dose by adding 100 milligram gradually. So that when you do that, they will have less side effects, better benefit, and give 2 months time and then they will be beneficial. And then you can wait up to 6 months to see the full response. Okay, I just thought that might be a...
Thank you so much. That was very, very helpful because it's absolutely true. And that's the reason why when patients come to us with neuropathic pain because of nerve compression, of course, we need to give them this steroid. And there are times when that steroid helps the immediate effect. I mean, I'm talking with cancer pain. So steroid helps it immediately and you start the pregabalin, they have already having the symptoms. So what happens is the steroid works for the first 1 week, then you're tapering your steroid, and by then gradually it takes about a week to 15 days for the neuropathic pain medications to start working. So that's the way we kind of titrate it. And there's a question about rib fractures. So usually in my setting, I see rib fractures along with because they are lytic lesions in those bones. So we usually see the fractures as pathological fractures. Honestly, I cannot do without radiotherapy. Palliative radiotherapy is the first thing that you need for skeletal metastasis. And I'm really grateful that we have a unit where they give them single fraction, even for palliative settings. They happily give them single fraction, even if the patient is really sick, because it's unbelievably helpful. So I think there, and that is a place where you might need an NSAID in a rib fracture. That is where I use my NSAID. Otherwise,
so traumatic rib fracture, I think you should follow the WHO ladder. Depends on the severity of the pain, and you could
and there your morphine will not help you. He'll just become drowsy. So even if the severity is 10 on 10, you will need an NSAID.
Yeah, correct. The only thing is that because in rib fractures, we cannot strap the patient or tell him to stop breathing. It can get very difficult to treat.
Very difficult,
So,
yeah.
So I think the NSAIDs are our saving grace along with PAN40 and improved hydration. I think that's the key that we need to tell people, because people have this notion that if you take too much NSAIDs, yes, it is dangerous to the kidney, but I think we also need to tell them about hydrating well when you're taking NSAIDs. Dr. Amrut Sindhu, I've not understood your word duration to titrate. Do you want to explain that, or has your question been answered? If you can unmute and talk, that will be great. Otherwise, we will move on to the case presentation and the doctor's advice to screen share. Okay, Kiran Vishnu has asked another, mirtazapine for insomnia, your experience, Vidya. Side effect profile.
See, again, I choose it very, very, when I, like I told you, I never give a medication only for insomnia unless the counselor has spoken and everything has happened. And so I will use mirtazapine if the patient has neuropathic pain, if they have an element of depression and not able to sleep. I start only with 7.5 milligram HS and then again build it up to 15 milligram HS. I don't even start with 15 milligram HS right away. So that is when I would like to use it. And of course, nausea, vomiting, patient is vomiting, all of these, if you have that little mix of symptoms, that's when I start.
Great. So can we move on to the case presentation? I think the doctor has been made a co-host. Yeah.
Dr. Smita, you can start your presentation.
Yes. Hi, good evening, everyone. I'm Dr. Smita. I'm currently working in the palliative care department of the General Hospital here in Ernakulam in Kerala. So to start with the yeah. So this is a 60-year-old female who is a case of CA right breast with mets to her lymph nodes as an axillary, subbiotic, liver, as well as liver mets and skeletal mets. Skeletal mets included metastasis to the 2nd and the 6th ribs, to her right scapula, cervical, dorsal, as well as the lumbar spine, sacrum, and the bony pelvis. Next slide, please. Right, so patient was admitted in the female oncology ward of the General Hospital on 1st of March, and she presented to them with complaints of pain in the left half of her body, including the side of the neck, torso, left to sit upright because of the pain. And she also said that she's had no sleep for the past 1 week due to the pain. In addition to that, she also had constipation for more than a week. So she was diagnosed with infiltrating ductal CA right breast in May of 2021. Following that, she had undergone one cycle of chemo at GH itself, and then she opted for Ayush treatment because of financial constraints. So she was under Ayush for 6 months, but then again, because of the severity of pain, she returned back to GH in February of this year for an onco consultation. Her whole body PET scan, it was done on 23rd of Feb, showed metabolically active, multifocal, primary right breast malignancy, metabolically active lymph node mets, hepatic mets, and active skeletal mets. And she was then referred to the palliative department for pain management. So prior to coming to GH, she was also started on oral morphine, 10 mg Q4H for a week before she got admitted in the GH. So along with morphine, we have also given her pregabalin, etoricoxib, haloperidol, and dalcolac. Can I have the next slide? But in spite of having 1 week of morphine, she still told us that there was no absence of pain. There was basically no relief of her pain. So then after getting admitted under the onco department on March 1st, we started her on DEXA 4 mg IV OD as well as Tramadol 50 mg IV TID. But the pain did not subside. And again, the onco department referred her to us for increasing her pain dosage. So on 2nd of March, she was anxious, oriented, and severe pain. And these were her vitals. Her SpO2 on room air was 96%. Her BP was 122/72. Her pulse rate was 82. And respiratory rate was 16 cycles per minute. On 1st of March, she had already got her blood investigations done, where the CBC showed a total count of 20,000. Platelets were 98,000. Her LFTs showed a total bilirubin count of 3.9. The SGOT was 537, and serum albumin was 3.1. Her RFTs were normal, with blood urea being 22, serum creat was 0.8, and her CT brain was done, which was a normal study. So because she still complained of severe pain, what we did was we increased her morphine dosage to 15 milligrams. And dexamethasone of 8 mg was started. And pregabalin was again continued at 75 mg, but it was given BD. Paracetamol on 650 mg. We also started lorazepam as well as haloperidol 1.5 mg and dalpax constipation. So earlier she was on 10 milligrams of morphine. We increased that to 15 milligrams. Prevalent, she was on 75 milligram OD and we increased that to BD dosage. And we also added paracetamol and lorazepam because of her insomnia along with the haloperidol. Next slide, please. This on the now, the 3rd of March, early morning at same, she developed desaturation where her SpO2 fell from. To examine her, she was very drowsy. She responded only to call of her name and to
Dr. Smita.
and her urine was a strong amber color. Her vitals at this point in time was 96% on 6 liters of O2. BP was 140/80. Pulse rate was 98. RR was 12 cycles per minute. So we told her to skip the 10 a.m. dose of oral morphine. She had already had the 6 a.m. dose, but we asked her to skip the next dose, which was at 10 a.m. and subsequent doses based on after we assess her. Next slide, please, ma'am. Again, at 12 p.m. when we assessed her, her GCS was still the same. There was no change. Pupils were still sluggishly reactive. No myoclonus was detected, but her respiratory rate dropped down all the way to 6 cycles per minute. So we immediately stopped all the medications and we decided to start her on naloxone, 0.8 mg IV. But the problem was we didn't have any naloxone at general hospital. So we asked the patient to procure it from a nearby pharmacy. But all the pharmacies in the vicinity did not have this. So he took a couple of hours to finally get naloxone and come. And it was evening 5 p.m. by the time we could administer naloxone for her. As soon as naloxone was was administered, within an hour, she showed improvement where her respiratory rate rose back to 14 CPM within an hour. And by 7 p.m., she was weaned off the O2 support. She was then alert and oriented. So the oncology again ordered her RFTs, LFTs, and serum calcium, but her urobag showed gross hematuria. So the next day, which was on 4th, when her test results came back, her total bilirubin was now 6.4. Direct bilirubin was 2.2, and SGO2 was again, there was a surge to 722, SGPT 197. Her renal functional test still was within normal minutes. Her arterial blood gas analysis was also normal. Her urine routine showed 25 to 30 RPCs. So she was again tapered down to Dexa 4 mg IV OD. Pantop was continued. She was given fluids with polybion and hepatic drip along with injection haloperidol. Paracetamol 650 mg was started again and suppository of Dulcolax. So these medications were then continued for the next week, but she still had absolutely no pain relief. She was still complaining of pain. So the oncology and parat departments explained about the terminal phase of her condition to the caregiver, but we were not too sure of starting morphine again for her. So just as the psychosocial aspect, she was basically a 60-year-old female who was a widow. She had 3 children, 1 son and 2 daughters, all of whom were married and with children. Her son's 4-year-old daughter was already diagnosed with Ewing sarcoma 3 years back, and that child is currently undergoing chemotherapy for the same. So they belong to a lower middle class family where the daughters are not working. The son works as a supervisor in a local supermarket. So all 3 were pretty grief-stricken over their mother's condition as well as the child's treatment. So they finally opted to resume palliative care at an ashram in Kottayam for both the mother as well as the grandchild. So patient was unable to tolerate the increased dosage of morphine along with the increased dosing interval of pregabalin in the presence of lorazepam. So because of this, we were hesitant to restart morphine for her despite of absence of pain relief on paracetamol. And another thing that we were quite confused with was, I mean, usually we learned that morphine, when you have signs of toxicity, they're supposed to have pinpoint pupils. But in this case, she continuously presented with sluggishly reactive pupils. And she didn't have delirium as such. There was no myoclonus, but respiratory depression was certainly present. So this is just a quick recap. It was a CA right breast with extensive meds to lymph nodes, liver, and bone meds. She was started on oral morphine at 10 mg, but because there was absolutely no relief of pain, we then increased it to 15 milligrams. And then she developed toxic symptoms, which were respiratory depression, shallow breathing of 6 cycles per minute. She was on O2 support with undue drowsiness. And finally, symptoms abated on administering naloxone. So one thing that we were surprised at was the absence of pinpoint pupils. And this patient, she can't afford buprenorphine or fentanyl. So we didn't know what else can we give if not for morphine. Thank you.
Vidya, over to you, and then we can take some questions.
I would just like all of you, thank you so much, Smita, for bringing this case, because it has so many areas where we can, have. But in the interest of time, I mean, can we stop screen share if it's okay, so we can get to see everyone's faces? So that please feel free to unmute and talk. My first question to all of you, including Smita, take a step back and think what you could have done better. Any thoughts? Immediate thoughts? First, Smita, can I ask you where the pain was?
So pain was entirely on the left side. She was complaining of pain right from the left side of the neck, her left arm, the left side of her torso, the left hip.
Yeah.
So I remember, Vidya ma'am, you had just mentioned in your presentation that bone pain does not necessarily respond to morphine, right? So yeah, so that was something that I had noted right now.
Please remember, and that's why assessment is key. So the patient can come each time with a different kind of pain. So if the patient has such, and exactly the way you described it and the PET CT, it almost corresponds to that area of pain. So suppose you have nothing. Suppose at that point you didn't even have Palarti or anything. 2 drugs that you could have started then. Anyone? The first drug that we use for bone pain. If you have nothing.
NSAIDs, topical NSAIDs.
Ibuprofen. Okay. Yeah.
Yeah, even before NSAIDs, because we are also talking of hepatic meds here, which we'll come to. But suppose the patient did. The first thing even before NSAIDs.
Can they have tried tramadol?
Zoledronate.
Very good for zoledronate, but the first drug is paracetamol. Please don't forget paracetamol. Okay. Give paracetamol Q6 hourly. You will be surprised at the difference. And if you have access to palliative radiation, that will help the best. There can be no comparison, because it's very important. And we are talking of a lady with metastatic breast diagnosed in 2021. And this is only 2022. So today we see so much of therapies with breast. So that we are not touching right now, but palliative radiation, and start with paracetamol and dexamethasone. When you know that
local infiltration.
Sorry?
Local infiltration?
No. You can just give oral. You can give oral.
No, local at the site of pain. If
no, so at the site of pain, palliative radiation will help the best. Because if you do anything there and the patient has, if it's in the spine and patient is having an impending cord compression, we don't touch the spine at all. We give a brace and we usually send them for RT. So we would have started with that. Now, I agree with you, Smita. Please come on. You were asking something. Please tell me.
Ma'am, we did give her Dexa 8 milligrams of IV, and we also started her paracetamol 650 mg QID.
Okay,
but
great.
Yeah.
Now, your next step, but you because I didn't see it in your first prescription, Smita. That's the reason.
Okay. All right.
Yes,
second prescription.
Yes, second one. And now coming to morphine, what is the dose that you would have started with?
We started.
The patient was already on 10 milligrams.
On 10 mg of, we started her with 10 mg of morphine.
Okay.
when she had come to the OPD first. So 10 mg of morphine. And generally at the OPD, we prescribe it for 3 days, after which the patient calls back and we monitor for any toxic symptoms. So she tolerated 10 mg well. But the problem was after a week, pain relief was not there, but there were no toxic symptoms though.
Yeah. So when we ask a patient about morphine, the question that helps is what happens to you after you take the medication within 45 minutes. If the patient tells you that there is no difference in the pain and I am feeling drowsy, and if I read it right, I think the respiratory rate was already 16, was the respiratory rate when she came for follow-up.
Yeah.
Okay.
Yes,
and the question, what happens to you an hour after you take the medicine? The patient will tell you, I only feel like sleeping, but the pain does not get relieved. Is a clear red flag sign for you to step back and think, I'm dealing with a morphine non-responsive pain probably. And, I need to go deeper into my assessment. The second very important thing over here was the hepatic derangement, right? So again, there are two parts here. One was your drowsiness. So this patient had multiple causes for drowsiness. And when the liver is impaired, there are two drugs which we try and avoid. And one of them is an NSAID and one of them is lorazepam, both of which we will hold. And here she had lorazepam, she had pregabalin, and she had an NSAID. So lorazepam could have very well contributed and also because you saw her liver enzymes going up in days. It was 3 point something on 29th, it came up to I think 6 point something, right?
Yes, within 2 days it came, within 3 days it came up to that.
Yeah, and you told me two other things that I read over there was, one was that you had put in a catheter, if I'm not mistaken. And
she was catheterized.
She was catheterized. And
the urine had gross hematuria. It was amber colored first.
But the amber color in urine is because of the bilirubin. So whenever we look at, when we think of bilirubin as yellow and we look at the catheter bags, I'm sure you look at the bags, it is never dark yellow. It is initially yellow, but after that it becomes that nice amber color. Many of times people think it's blood, but it isn't. But yes, you had a 25 to 30 RBCs. That could be because her TC was also 20,000. So she could have had a UTI also, or she could have had a 4E catheter-induced infection, which could have caused that. So, and another thing for insomnia, the first sign of delirium, can any of us talk about that? The first sign of delirium in a patient? That's usually what we call as altered sleep-wake cycle. So that's the first sign of delirium. So when your patient tells you that I am not able to sleep at night, but I am drowsy in the day, it is the first sign of delirium. And in a patient who is going into probably hepatic encephalopathy, this could have been her first sign, could have been more delirium related rather than insomnia related. So in fact, those would be the ways that we would approach, assess, and then her drowsiness, the contributory factors are way too many. And another thing was you gave her 10 milligram morphine, but did she take any breakthrough doses?
No, ma'am, she didn't take any breakthrough doses.
When somebody doesn't take breakthrough doses, it means the drug is not helping them. If they have understood and they are not taking the breakthrough doses, it means it's not helping them. Then we shouldn't be raising it to 15 without asking them. Because the minute we do that, we are going above. Because the criteria for increasing the dose is how many breakthrough doses. We calculate that and then go 3 days later. So these are a few thoughts that just came immediately. But Amelia, I can see you there. So please.
There are a few questions also, Amelia, before you add to with your experience. One is, what about palliative to the radiation to the right breast? I think bisphosphonate,
bone, or the area of most pain. So when we are left with a whole skeleton, and you have a problem, we usually go by area of most pain and discuss with the radiation oncologist. That's how we practice.
Bisphosphonates, Amelia and Vidya, and also why was she on haloperidol is the question from Shilpa Khanna.
Again, insomnia was the issue, so we started her on haloperidol.
Okay, what Vidya, you would like to comment on that?
I would first, like I said, the delirium part, it would have helped. But if she was nauseous and vomiting, I would have first addressed the other things first and probably given her olanzapine, because that's what is available easy with us. I know that Kerala, you get haloperidol very easily. We don't get it.
I, to be honest, didn't realize that respiratory physicians will have so much questions on pain. And I think one of my feedbacks back to Pallium would be a separate talk on pain for the
Yeah, I think it's needed, because especially with so many questions, it should not have been done today.
And it's needed for the people to listen, because once you're actually dealing with patients, sometimes you're tearing your hair apart saying, what else can I give this human being and how can I deal? And pain is such a painful, nobody should be suffering any kind of pain. I think that's why we are all so keen in learning palliative care medicine. So I will take back this suggestion to Pallium India that the next session for respiratory physicians should have pain and then the other symptoms of insomnia, fatigue, psychosocial, as well as loss of appetite. Any other last minute thoughts, suggestions?
Amelia.
Yeah, I just wanted to say that Vidya, it was a fantastic talk. But even in the case of this patient, I think the talk that you gave about anxiety, about the psychological factors, that's one of the other places where even if you give morphine, it's not going to work. You just make them drowsy. It's not the pain relief, because she already has a grandchild who's got Ewing sarcoma. She's got 3 ladies at home who are not working. So the psychosocial system that was actually mentioned by Smita ma'am actually goes a long way to say that the importance of assessing what the pain is, the importance of assessing and putting down together what are the causes that are there that is causing this lady to complain of pain. Because whatever you feel inside, actually physical pain is the most easiest thing to express. They are not able to express any of the other pains that easily. So they just say pain. So if you actually look at pain, total pain, physical pain is just the iceberg, the tip on the top. It's the thing that is right down, which causes most of the problems, that if you don't assess it, then it becomes difficult. And the thought that morphine is an answer for everything is difficult, especially if there are tumors, you think it is going to be because of that. Many times it isn't. We were referred a patient recently. He had been on a fentanyl patch. He had been on everything for pain. And he had become drowsy. He'd become bedbound, very, disoriented and very sleepy and not responding, not eating. But when we finally sat down and asked, what is your pain about? He hadn't opened bowels for 10 days. Patch was taken off. Half the medications were taken off. Bowels were regularized. He's fine. So it becomes very important, like Vidya actually said, especially the Edmonton Symptom Assessment Scale is something that everybody can use. And it gives you wonderful perspective as to what actually is troubling a person. But it's amazing. And Smita ma'am, it's just a thought that if in a government situation, if you are going to use morphine, you should have naloxone. It's a blessing that the patient didn't have further decline while the husband was while the son was looking around for naloxone. But if you are going to prescribe morphine, you should have its antidote with you in the hospital. For your own safety, for medical legal cases, you should have it with you.
Sure.
Yeah.
Thanks, Amelia. Good to see you.
You too.
With that, I thank Vidya for spending so much time with us. And I know we had a couple of sessions discussing of how much should we serve the respiratory physicians? Is this much enough or too much? Because it can get a boring.
I still don't have the answer to that.
But I think there is a lot of interest generated. So pain should be a separate topic from henceforth. And so Rajlakshmi, that's our homework. And over to you. Thank you once again.
Good collaborative research. I think it's time for us to do it.
I agree. And we really probably realize how pained our patients are also, because we don't ask them about it. We don't know. And I'm sure once we start asking, we will realize how inequipped we are to deal with all that. And the next week, I think Rajalakshmi will give you the